Yeah. So I'm Dr. Selva Kumar, Professor of Department of Periodontics of Adiparasakti Dental College. Today I'm going to talk on desquamative gingivitis. First of all, I thank the opportunity given by the people from Saraswati Dental College. I'm just going to share my knowledge on desquamative gingivitis. Yeah, this is the college where I'm working. This is from where I'm speaking right now, from here, from my perio department. So, with the blessings of Almighty and my teachers, I'm what today is because of these people. My perio teachers, my PG teachers, my undergraduate teachers, my oral pathology teacher, and my principal and oral medicine HOD. He was a senior lecturer when I was doing my PhD. Sir was instrumental in helping me to know about this desquamative gingivitis. When I was doing my PG days, I'm not understanding because most of us we think that desquamative gingivitis is some sort of vague topic. We most of the time we skip the topic, but sir has taught me basically about what is desquamative gingivitis, and I got fascinated towards this part of perio chapter. So desquamative gingivitis, what I'm going to talk today. First of all, I was not sponsored by
respected sir,
yeah.
Can you do full screen in this, sir?
Yeah,
because we are able to see the screen, slideshow rather, I would say. If you press slideshow, we can see only one slide.
Selva, your slides are not moving. They are just starting on the first one.
Okay, sir. Just a minute. Is it? Now is it visible, sir?
So the main slide is visible and the side slides are also visible. Possible that we can do a slideshow, sir?
Just a minute.
In the lower right corner, you will have an option of slideshow.
Yeah, I did it. I don't know, it is showing us. Wait, I'll.
Okay, no problem, sir. Let's go ahead.
Just a minute.
Let's. No problem, sir.
Just a minute, sir.
Right, sir.
நமக்கு வந்த பேஷண்ட் யாருமே திரும்பி வருது கிடையாது. கிளாப் பண்ணாலும் சரி, என்ன பண்ணாலும் சரி, எதுவுமே வருது கிடையாது. They are not. நம்ம follow up இல்ல.
Is it visible, sir, now?
Sir, no problem. The slide is visible.
No, is it visible now? I'll just restart.
Students are not following up. இது வந்து ஹைஃபையா இப்போ ஆன்லைன் சொன்னீங்களா அவங்க பாடி எழுதி அனுப்பி விட்டுருவாங்க பேஷண்ட். நானா இங்க பாத்துக்கிட்டு நம்ம எல்லாம் ஓடுவோம், நம்மள சாவடிப்பாங்க. நான் அந்த மாதிரி மட்டும் பண்ணேன்னா தொங்க விட்டுருப்பாங்க இந்த டிபார்ட்மெண்ட். they won't even see. இந்த மாதிரி நான் அனுப்பி விட்டேன்னா ஃபர்ஸ்ட் திங் பேஷண்ட் கூட பார்க்காம யார் எழுதினது பதில் சொல்லுங்க.
डॉक्टर चेतन, आप सबको म्यूट कर दीजिए.
Okay.
Is it visible? Is it visible now, sir?
ஸ்பெஷல் கேஸ் என்னதான் அவ்வளவு பிஸியா இருக்காங்கன்னு தெரியல.
Yeah, Dr. Chetan?
Yes, sir. Good. No problem, sir. Please go ahead, sir. No problem.
How is
the
it
slides are
visible?
visible. Slideshow is not there. That's not a problem.
Is it coming or not, sir?
Yes, the slide is coming. Don't worry, sir.
Okay. Full screen. Was it visible? Just a minute, sir.
Dr. Silva, good morning.
Yes, sir.
Please start. I guess there is some.
Yes, is it clear, sir?
Uh,
What happened? It is showing as passed, sir. Have you given the screen sharing?
yes, sir. You are co-host.
Is
Just
it?
move your slides.
Yeah. Is it visible?
Slide. Your slides are not forwarded.
Is it visible now?
Slides are visible, not in slideshow, but it's okay. These are moving.
Now is it visible?
So don't worry, slides are visible,
Taraf
sir.
chal rahi hai, हाँ.
But that's not a
Okay.
problem. Please go ahead with the presentation, sir.
Yes, sir.
Yes, sir. Please go ahead, sir.
Yeah. Sorry for the delay. Disclaimer, I'm not sponsored by any company or anything. Just I'm sharing my views on it, either for the undergraduates, and I see lot of faculties and extremely EC members of ISP. So it is just I'm sharing my knowledge on desquamative gingivitis. Most of the pictures whatever been shared here are taken from the book for easy understanding, and some photos are from my own cases, and I've been treating the cases with photo biomodulation and photodynamic therapy, which I'll be presenting it during the course of my presentation. If you have any doubts, I cannot visualize, so if you have any doubts, write it in the chat box and I can say about it. These are the possible questions they can ask in the exam. What is Nikolsky sign? Stomatitis medicamentosa, steps in diagnosing, what is severe bodies, cicatricial and bullous pemphigoid, tombstone appearance, Shank cells, acantholysis, sawtooth appearance, tombstone appearance. All these things can be asked in your exam. If you are an undergraduate or a PG student, these questions can be asked in your Viva OC, or not only for that, even for the diagnosis of certain diseases. In this post-COVID era or during this COVID era, we see lot of cases with viral oral manifestations. For that, we have to know the diagnosis of the these cometic, which is very important. So these are my contents of the topics what I'm going to talk today. So a patient comes with the complaints like burning sensation in the mouth, or there will be a simple desquamation, or there will be bleeding gums. Postmenopausal women or women, it's a very irony. They can't eat, even drink water also. I've seen some cases where patients we can't do much about it. That is the condition they come for it. Or sometimes we mistake it for simple gingivitis and we start the treatment. So as a dentist or as a periodontist, we have to look out for everything whatever is being shown here. So if you find the gingival findings, look out for all these conditions. Patient is coming with something like ulcer like this, you mistake it for aphthous ulcer or some other major aphthous ulcers, or some drug eruptions you might think. It could be a case of pemphigus vulgaris also. So for those reasons, it has to be known. So you have to know the proper diagnosis of desquamative gingivitis. Yes, pessimist sees the difficulty in every opportunity, and optimist sees the opportunity in every difficulty. Most of us say we periodontists are not having much of cases. It is not so. We are not diagnosing the cases properly. As an optimist, I see the opportunity in every difficulty. When I started my practice, before I joined my perio also, I went to a dermatologist and general physician, diabetologist, tell them that there are some periodontal findings which we can treat it, then only they can refer the cases. Most of the cases what I am going to show you here today would have been seen by a general physician or by a dermatologist or by a ONG specialist. So, we periodontists, it is our duty. This is how we can increase our perio practice. Go and speak to them. These are the conditions. We will also be able to treat them. So, kindly refer the case. So, be optimist in whatever the presentation or whatever the treatment you are going to do it. So, history about desquamative gingivitis. Initially, Prince in 1932 coined the term chronic desquamative gingivitis when he see a bunch of patients with desquamation, ulceration and bleeding of the gingiva. Then McCarthy and colleague in 1960 coined the term desquamative gingivitis, and Glickman and Smullo in 1964 has come out with a classification on lichenoid reactions and Bula's type of lesion. But they were thinking it might be because of anemia, or it can be due to, because it affects the females, they were thinking it could be because of the estrogen deficiency. They were seeing lot of cases, erythema, desquamation. They are thinking up, so it could be due to endocrine dysfunction. So the etiology was unknown for quite some time. Even till now, the etiology is unknown in certain conditions. But overall, they have identified maybe this could be the reason for the diagnosis. So before going into the my topic, I want you to know about what is a papule. Anything elevated solid lesion which is less than 1 centimeter is papule. When it is flat and less than 1 centimeter, it is macule, which is different from the adjacent skin. Patch, if it is more than 1 centimeter, you call it as patch. If it is circumscribed, well elevated lesion which is greater than 1 centimeter in diameter, you call it as plaque. First of all, we have to know what is the difference between vesicle and bulla. Vesicle is the fluid filled collection which is less than 0.5 centimeter in diameter, whereas bulla is where it is greater than 0.5 centimeter in diameter. Here you can see the vesicle, a small vesicles are seen. Here you can see what are the bulla. So nodule, you can see this is a solid lesion which is greater than 1 centimeter in diameter, and it is a firm lesion. It can be a tumor and wheal also. Pustule is a purulent material containing filled cavity, is called as pustule. So with this basic thing about what is bulla, what is pustule, because these terminologies is going to be used often in my presentation. So you have to know the basic about bulla, vesicle, etc. So chronic desquamative gingivitis, it is characterized by intense redness, desquamation of the surface epithelium of attached gingiva. It's called as chronic desquamative gingivitis. To explain it, the pathogenesis takes place at the basal cell layer, in the basement zone and in the connective tissue layer. This is the one which we are going to deal about it. Keep this picture in your mind. So this is going to be your epithelium, this is going to be connective tissue. In the epithelium, there is desmosomes are there. The desmosomes are connected by desmoplakin like this, and there is this desmoplakin is going to be connected to the keratin filaments like this, and this keratin filaments are connected to hemidesmosomes, and this is connected to the PP180 proteins.
So your slide
what,
is not changing.
can you mute it please? So what happens in this oral keratinocytes, there are, due to some etiology, autoantibodies develop against this plaque, either at this desmoplakin level or at the basal keratinocyte level.
Yes, sir. Sorry to disturb you. Sorry. Sir, slides again are not moving. They're, I guess, freezed.
Okay, just I'll change it with the other. Open
Yeah,
it.
sure, sir.
Just a minute, sir.
जी sir, कोई बात.
I'll connection yeah. I'll camera. அவன்கிட்ட அவனோட இமெயில் ஐடி பென் டிரைவ்ல காப்பி பண்ணி கொடுத்துருக்கேன். எனக்கு இப்போ ஞாபகம் ஜி இசட் இல்லைன்னா காலேஜோட மெயிலில் வரணும். Is it visible now, sir? Is it moving?
Not at the moment, sir. I think you can close the PPT and reshare the programs. Reshare it, sir.
Just a moment. I don't know where I am now. அந்த பென் டிரைவ்ல காப்பி பண்ணி கொடுத்துருக்காங்க. இங்கிருந்து ஜூம் எதுவும் Sorry, sir. Just a minute.
No, sir, your lecture is so interesting that I think so many people are waiting just to listen to you, because it's just a technical glitch. It will be solved, sir.
For me, is it visible now?
Yes, sir.
It's not moving?
Try to move the slide, sir.
I'm moving, sir.
Slide 1 is visible only, sir.
Yeah. Just I'm logging in through the other computer.
No problem, sir. No problem, sir. No problem, sir.
Now is it visible?
Yes, sir. It has moved. What is Nikolsky's sign? Yes, it's moving, sir. Please go ahead, sir.
Now it is moving, no?
Perfect, sir. Perfect.
Yeah. Now is it full screen?
Right, sir.
So till this it was visible, no? These pictures are very important. Yeah. Now is it visible, sir?
Yes, sir.
Screen
Go ahead,
is
sir.
moving, no? Screen
Perfect,
is
sir. Perfect, sir. No problem, sir.
So till this I have covered now. So with this picture I am going now. So this is the basal keratinocyte, what I was mentioning now. Desmosomal plaques are there here, desmosomal plaques. This is the subepithelial layer, and this is going to be your connective tissue. Any auto antibodies developing against this is going to lead to your this desquamative gingivitis. So it could be desmosomal plaques. There might be autoantibodies developing against these desmoplaquins, or there may be autoantibodies developing against BP233, BP180. This leads to pemphigus vulgaris, and this leads to mucous membrane pemphigoid. So all these autoantibodies developing at this level will lead to this disease, desquamative gingivitis. So in this, in the basal keratinocyte layer, these are the proteins which you can see in the connective tissue. These are the targeted proteins which gets affected. So if you can see in pemphigus vulgaris, it's desmoglipin protein, and bullous pemphigoid, it is BP. In case of erythema multiforme, it is desmoplaquin. So all these proteins are getting affected. So with this you can understand it is the autoantibodies developing against those particular proteins that is causing the desquamative gingivitis. But we have to know the other etiologies. It could be because of the dermatological disease, or it could be because of some endocrine disturbances. This is what previously they thought, because of the estrogen deficiency, or sometimes they thought due to the abnormal response to bacterial plaque. Now it has been proved it is non-plaque induced, or it could be because of chronic infection, and it could be idiopathic. Sometimes the drug eruptions, all those things can take place, and due to the aging also. But there are various classification of desquamative gingivitis diseases are there. We are going to three most commonly seen is mucous membrane pemphigoid, oral lichen planus, pemphigus vulgaris. These are more common. These are all, they have the clinical manifestation of desquamative gingivitis. So desquamative gingivitis is not a disease by itself. It is a clinical manifestation of various systemic diseases that you have to keep in mind. Coming on to the clinical features, there might be warmth, tenderness, tingling sensation, burning sensation, pain, chronic soreness. These symptoms are common for all types of chronic desquamative gingivitis. Regarding color, it could be rose in color, or it can be fiery red in color also. It can be smooth or shiny surface. Sometimes it's ulcerated, bleeding can be there, edema or erythema, either it can be a localized or diffuse, or there can be a loss of stippling, and all these things can take place. It can be localized or systemic also. So severe involvement can be there. So it affects various parts like cheeks, heart, soft palate. We are bothered about the gingiva. Some patients have gingival lesions also. Coming on to for differential diagnosis, these are the things you have to see. What type of bulla is it? Is it a flaccid or tense? If it breaks faster, it is called as pemphigus vulgaris, where there is a rapid bursting of bulla will be there. When it spreads laterally, when you press the bulla, when it spreads laterally, it is pemphigus vulgaris. Appearance in cicatricial pemphigoid and leukoplaque, it could be more hemorrhagic, whereas in case of pemphigus vulgaris, it is shallow. And most of the time, keep in mind, the positive Nikolsky sign is one of the clinical indicator for desquamative gingivitis. So as I mentioned already, either you can use a blunt instrument or airway syringe to elicit that Nikolsky sign. So it could be a localized or it could be a generalized desquamative gingivitis. You have to take a proper case history, which is very important. Ask the patient about the duration, location, frequency of lesion, triggering factor, family history, symptomatology. Whether they recognize the pain or not, you have to identify. Then look out for not only the oral mucosal lesion, look out for the skin lesion, examination of the eyes, etc. Other than that, your biopsy, serological examination, immunoglobulin study, biopsy can be done, immunofluorescence studies can be done, histological sectioning can be done. From this only we can come to the diagnosis. So there are some disorders of epithelial attachment which I will be dealing about it later. So you know two things, there are direct immunofluorescence and indirect immunofluorescence test. So this is how we do the immunofluorescence test. I don't want to go in detail of it. So as I was mentioning about autoantibodies in the immunofluorescence, this is what we will be seeing. In pemphigus vulgaris, IgG, IgA, IgM at the intraepithelial layer. Like that we will be seeing lot of findings autoantibodies in various conditions we will be seeing about it. Other than localized and generalized, these are the common forms which we see about it. Mild form of desquamative gingivitis, which is erythematous but painless most of the time. Mostly it affects the females. Coming on to the moderate form, it is bright red in color, smooth and shiny, slight pitting with pressure. When you massage, it peels off and leaves behind a raw surface, which is an indicator of Nikolsky sign. Mostly it affects 30 to 40 years of age group. Severe form is one which we are very much bothered also. There is a wide area of oral cavities involved. Surface epithelium appears shredded, very painful. Patient coming with the complaint of burning sensation. Most of the time the patient comes with this complaint only. So coming on to the treatment, most of the time the treatment can for desquamative gingivitis is, first of all, we have to eliminate the cause and we have to improve the oral hygiene. I mentioned you already, plaque doesn't causes the desquamative gingivitis, but the desquamative gingivitis will impede the patient from doing a proper oral hygiene measure. So it leads to more accumulation of plaque, which aggravates the disease. So in that case, we have to improve the oral hygiene of the patient, then find out the underlying pathology, whether systemic or oral, do a biopsy and do the treatment. So in that case, you can use corticosteroid ointments or creams, even nasal sprays are nowadays available, which can be used, and mouthwash. You can use prednisolone, soluble prednisolone are available, betamethasone is available, fluticasone is available, which can be mixed with 15 ml of water and ask them to gargle it. Other than that, we can also do, there is recession, post-recession developing after desquamative gingivitis. For that, you can do some mucogingival surgery, and lasers have been shown to be very effective, but most of the time it is the corticosteroids which is important for treatment. Either the local or systemic antibiotic therapy is going to be the treatment of choice. And sometimes we do this plasmapheresis, where the blood from the patient is removed, autoantibodies are isolated, then the patient is transfused with the same blood. Sometimes we can also give labial veneers in this case for recession cases, but mouthwash and antibiotic, mouthwash and corticosteroids are the line of treatment for desquamative gingivitis. There are some other disorders, as I mentioned you already. It is the clinical symptom of various systemic disease. Whatever I mentioned here, all these contribute to desquamative gingivitis. It could be a mucocutaneous lesion or endocrinous lesion or chronic infections, idiopathic drug reactions, or other diseases that mimic that of desquamative gingivitis, which we are going to see about it. First, the oral lichen planus. It is a immunologically mediated mucocutaneous lesion. Patient coming with a white striation with reddish inflammation, where T cell plays a central role. It is a oral lichen planus. It commonly affects middle-aged and older individuals, and it mostly very severely affects the females. And the etiology for this is, all this can be a etiology for lichen planus. Idiopathic stress, traumatism, malnutrition, autoimmune disorder, hereditary Greenspan syndrome. So as I mentioned already, still the cause of oral lichen planus is not known. The pictures here shows how lichen planus appear in the skin, flat topped bumps, it affects the skin. But in the oral cavity, you can either see four types are there. One is atropic, one is reticular pattern, this is the reticular pattern, and the other one is erythematous pattern. So all these classifications of lichen planus are there. As I mentioned, erosive lichen planus and reticular lichen planus are very severe condition. Erosive lichen planus is the one which we have to see about it. So reticular pattern, this is the more common form, usually asymptomatic. You can see white lines, along with that you can see some white lesions there. So these can come and go off as and when. So this affects gingiva also. So it could be it can be in the buccal mucosa or in the reticular area. Erosive lichen planus, usually patient comes with this complaint. Sometimes we mistake it for linear gingival erythema or gingivitis also, simple gingivitis also. Be careful. It will be atropic erythematous area with striations at the, you can watch here the striations at the periphery. So if white striations are there, it could be there. So in the facial area as well as in the palatal area, you can see erosive lesions. So same way in the gingiva also, and you can see a striae like this, white striae, reticular pattern, and in the lip also you can see it. This is most commonly which is the area which we see about it. Then in the palate, erosive lichen planus can be seen in the palate like this, and atropic lichen planus. Coming on to the histological section, the lymphocytes accumulate more in amount here. Because of that, the retipex, which is normally something rounded one, becomes sharp. So it becomes a sawtooth appearance, as it is shown here. due to this lymphocyte infiltration. I told you it's a T cell mediated immune response, the immunomodulatory reaction. So what happens, the T cells, the retipex will become sawtooth shape appearance like this, and like this you can see sawtooth appearance. Hypergranulosis is there, and there is atrophy of the cells will take place, leading to severe bodies. So coming on to the differential diagnosis, these can all be the differential diagnosis for the lichen planus. So what is going to be the individually, I am telling now, what is the treatment for lichen planus? Mostly if there is asymptomatic, no therapy, just follow it up for 6 to 12 months, because it can manifest into squamous cell carcinoma. So in case of erosive cases, if it is initial stage, the early treatment is very important. You can give topical steroids, or if there is no resolution, refer to dermatologist. In case of severe cases, you can give injections of steroids, resolution will be there. So this is about oral lichen planus. Coming on to the pemphigoid, it is a cutaneous, first manifested in the skin, immune mediated subepithelial bullous disease that are characterized by the separation of the basement membrane zone. It could be bullous pemphigoid, mucous membrane pemphigoid, pemphigoid gestationis. What is mucous membrane pemphigoid? It is otherwise called as cicatricial pemphigoid because it goes into the connective tissue, so it causes scarring of the tissue. So you call it as cicatricial pemphigoid, and this have a multiple organ involvement. So we have some 5 subtypes of there. What has been mentioned here, it is a chronic vesiculobullous lesion affecting the women of 5th decade of life. So as the pathogenesis elicits, due to the collagenase and release of proteases, it forms a blister formation in between the basement membranes. Think about that keratinocytes. In between that keratinocytes, there it forms a autoantibodies, blister forms. In case auto degeneration takes place, that might lead to blister formation. So there is a cytokine release also, autoantibodies developing, leading to raw wound surface. So this is how the it is shown as clinical feature: erythema, desquamation, ulceration and vesiculation of the attached gingiva. The bulla are thick and they are ruptured in 2 to 3 months. So vesicle or bulla, if it is seen in the gingiva, it is desquamative gingivitis, and it is positive for Nikolsky sign. So when you do the Nikolsky sign here, you can see a vesicle has formed after rubbing it with the your blunt instrument or your flat end of the probe. So it can be erosive, and it can be like this. It is involving the labial surface of the gingiva or in the palatal mucosa, and you can see the localized lesion like this also. So as I told you, it can have multi-organ involvement. First, the ocular involvement. Whenever you want to diagnose MMPs, first if there is going to be, look out for eye problems. If they have symblepharon or ankylopharon where there is an adhesion of the eyelid takes place with that of the cornea, then you call it as symblepharon or ankylopharon. So this can lead to scarring, corneal damage and blindness. There will be vesicles present in the conjunctiva which eventually produces scarring in these cases. If it involves the nasopharyngeal involvement, it can cause rupture of the vesicles in the nasal mucosa, sometimes leading to dysphagia, dyspnea and laryngeal stenosis also. Other than that, you will also have pemphigoid gestations where it's a severe condition where you can see a hemorrhagic bulla on the gingiva. This is what I mentioned you. Now this is the connective tissue layer, this is the epithelial layer. Now there is a due to always read the clinical feature with that of the histological features. What happens is this: at the connection of the cells, there will be a cleft developing, there will be a separation of the corium or the connective tissue from the edematous epithelial cells. So this leads to a bullard formation. This bulla ruptures and leave behind the raw surface in the oral cavity. So this is how the bulla forms and takes place. So in the immunofluorescence study, you can see an Ig antibody here. So there is going to be IgG stain, C3 proteins will be seen in that. So these are the differential diagnosis for MMPs. And what is the diagnosis? If the patient is asymptomatic, just good plaque control is essential. If it is mild to moderate desquamative gingivitis, apply topical steroids. If severe cases, refer to dermatologist, give a prednisolone, and even dapsone can be added up. Coming on to the bullous pemphigoid, it's a chronic autoimmune subepidermal bullous disease with tense bulla, which becomes flaccid in the skin like this. It is going to be very tough here. So, if you find a finding like this, you have to think about bullous pemphigoid. Oral lesions in bullous pemphigoid is less, but there might be presence of vesicles, erosions and ulcerations. Extremely painful conditions. So, gingiva appears erythematosus in this condition. So, the patient will be complaining of pain here. So, you can see a blister, you can see a bulla here. So, these findings can be there. So, what happens in bullous pemphigoid? There will be subepithelial vesicles below the epithelium. There will be subepithelial vesicles will be there. There will be break in the continuity between the basal lamina and basal cell membrane. There is no acantholysis in this case of bullous pemphigoid. IgA is present here, IgG and C3 is present here. So, treatment is going to be, again, as I mentioned you already, control the signs and symptoms. Steroid sparing drugs, what do you mean by that? So, if you are giving steroids for desquamative gingivitis, the steroids can have other side effects also in a long run when the steroids are given. To overcome that, they have added immune modulatory drugs which enhances the immune modulation of the patient, and this is what you call it as steroid sparing strategies or steroid sparing drugs. So, this is what we have to know about it. Along with the steroids, you have immune modulatory agent. Coming on to the pemphigus vulgaris, it's an autoimmune disease involving the skin or mucous membrane. It's a bulla formation. Here the pemphigus is bubble or blister. There are 4 types of there: pemphigus vulgaris, pemphigus foliaceus, vegetans and erythematosus. Vulgaris and foliaceus are more common, and it can be potentially fatal disease that affects oral mucosa. So, these are the different types of what? Excuse me. Yes. These are the different types of pemphigus vulgaris, and you can see what the autoantibodies, what are the antigens affecting. So, we have to know about it. If you think this picture, we have read in our gingiva chapter. So, the pemphigus affects this area in between this, the desmosomal gene of 3 desmosome here as well as here in the basement membrane zone, they affects. It affects here. So, the autoantibodies develop against these fibrils, then only we develop pemphigus. So, circulating autoantibodies are responsible for disruption of intercellular junction. So, extraorally you can see fully the skin lesions. As I told you, the bullar ruptures leave behind the raw surface. Mostly it affects adults, and females are more prone, and it could be genetic origin also. Then it is the first lesion seen in the oral cavity, then only they go for the dermatological manifestation. So, as we dentists, we are the one who will be seeing the first case, and it will disappear even after good therapy. After dermatological lesions wane away, then only your oral manifestation subside. So, it is very erythematous, it has a ragged area, and it is positive for Nikolsky sign. So, you can see it is ragged here, again it is ragged here. These areas can be very much erythematous and causing this. So, lethal chronic condition, 4th decade of life, and it can affect the mucosa or in the tongue also. Pemphigus vulgaris bullous lesion also, sometimes we mistake it for again atypical gingivitis. So, it is a painful area of the erosion. So, always look out for the history of the patient, that is very important. Skin also you can see it. Here you can see acantholysis. I was mentioning you earlier, civate body, shank cell, tombstone appearance. Here the tombstone appearance, what happens is first the shank cell, the cells they get degenerated, they will have a free floating cells within the blister fluid like this. So, that is called as the shank cells. And tombstone appearances, there will be an internal interepithelial clefting takes place. Because of this epithelium with the basal layer will look like a tombstone. In the graveyard you can see tombstone, same way you can look out like this. So tombstone appearance, if they ask you what is a tombstone appearance, you have to know that it is seen in pemphigus vulgaris. And typical immunofluorescence study, you can see chicken wire appearance. These terminologies you have to keep in mind. So these are the differential diagnoses for pemphigus vulgaris. So if you see a pemphigus vulgaris, primary treatment, refer to a dermatologist. If the oral, same whatever the treatment plan what I told initially can be followed it up. Prednisolone can be given, then it can be decreased and maintained for a dosage. Initially the starting dosage, they will go up to 120 mg, also 170 to 80 mg they go for it. Then they reduce it for 35 to 40 mg also. So secondary treatment along with methotrexate, plasmapheresis, I told you already, have been tried out. Coming on to the chronic, these three common diseases, whenever they ask oral lichen planus, mucous membrane pemphigus vulgaris, these three are very common. Now I am telling you the other conditions which can also be seen in the desquamative gingivitis. Chronic ulcerative stomatitis, it's a painful solitary small blisters and erosion surrounding erythema in the gingiva and tongue. So we have to know about it. These, like this, you can see the condition. So histopathology, hyperkeratosis, acanthosis and liquefaction of the basal cell layer will be there. What is the treatment? Topical steroids, systemic steroids, hydroxychloroquinone sulfate is the treatment. Linear IgA dermatosis. I have some interesting finding at the end of the presentation. To just you know about this, whatever the disease, we will find out how to diagnose it at the later stage. So uncommon mucocutaneous lesion, pruritic, as I told you, pus filled cavity, vesiculobullous rashes can be seen. So vesicles, which is seen in a hard soft palate, gingiva also it is seen. So you can see a linear IgA dermatosis, it will be like this, and typical features like the linear deposits of IgA are seen. There will be polymorphous nuclear leukocyte infiltration, similar to that of erosive lichen planus will be there. So differential diagnosis, we have to know about it. Treatment, in case of early stage, you can give prednisolone. Tetracycline can be combined with nicotinamide, and mycophenolate has been given. Dermatitis herpetiform, it affects the young adults. Here you can see it affects the males. It can be bilateral, seen in the skin first, then in the oral cavity, skin lesions like this, and the oral mucosal lesions. So you have to know about it. So in this case, you can see histopathological and immunofluorescence studies also. What is the treatment for it? Gluten-free diet, dapsone, which is normally given for leprosy patients. Oral dapsones can be given. Coming on to the lupus erythematosus, there are two things are there. Systemic lupus erythematosus, discoid lupus erythematosus, chronic cutaneous. It could be due to the genetic predisposition and patient are prone for some genetical problem. Along with that, if there is going to be immunological abnormality, these two combined can lead to autoimmune disorders. So it is more common in females, affects other organs also. So oral lesions, 36% have systemic lupus erythematosus. So it is seen in palate, gingiva, oral mucosa. Histological findings are there. There are multiple abscesses also are seen in these conditions. Chronic cutaneous lupus erythematosus, it is otherwise called as discoid lupus erythematosus. If it affects the skin, the scarring will be there in this condition. So just you can know about it, subacute cutaneous lupus. What is the treatment for it? If it is cutaneous lesion, topical steroids and sunscreens and hydroxychloroquine can be given. Mucosal lesions, topical steroids, systemic involvement, you can give moderate to high dosage of prednisolone. Coming on to the erythema multiforme. So far I was telling about chronic desquamative gingivitis. Chronic conditions. Here it is an acute case where you can have a bullous or macular inflammatory mucocutaneous disease. Young adults between age group of 20 to 40 years are affected, and you can see the lesions. The typical feature here is you can see a target, bullseye appearance or targets you can say. So they will be asking you in the exam in which condition you can see bullseye or targets appear. You can see a small halo in the center surrounded by the erythematous border. So most of the time it is flat, round, it is bulbous. So it affects the young adults, oral mucosa skin. We don't know what is the cause. Sudden onset it can be there, or after fever, malaise, headache, sore throat. And when I was speaking with a physician, they told me a lot of cases have been reported for erythema multiforme or for the post-COVID. So we are having an opportunities there. So it is our duty to diagnose properly. Hemorrhagic crusting of lips, buccal mucosa, erythematous patches, painful, difficult to examine. Patient will be having lot of pain with this condition. So I've treated some cases with photobiomodulation. Photobiomodulation is very effective in these cases. In a course where I did, they have showed me with photodynamic therapy also. It gives an excellent result within a short interval of the time. But it requires multiple visits, but the remission is common. So the complete repair and healing takes place with this condition. As I told you, targets are. And the one more thing in histopathology is, you can see intraepithelial microvesicles are seen. There is a liquefaction degeneration of the upper epithelium with microvesicles, that is abscess taking place. The micro abscess are there in this condition. So that is one of the indication in histopathological case that it could be a erythema multiforme. Again, treatment, corticosteroids therapy is not necessary for mild form. Sometimes Stevens-Johnson syndrome, patient taking tablets or another fever, malaise, they can, after that they can develop Stevens-Johnson. It's a severe bullous form. Sometimes we mistake it for ANAC. There is ulceration with bloody crusting are there in the gingiva. Toxic epidermal necrolysis, this is a severe case of erythema multiforme, or it could be a Stevens-Johnson syndrome. So differential diagnosis or this. What is the treatment? The most of the time if you do spontaneous treatment, mild cases systemic and local antihistaminic, topical anesthetics. I used to give a magic mouthwash. Magic mouthwash contains this, it was told to me by one physician and oral medicine doctor who has done a study. It contains anti-allergic, anti-anesthetic, so that was very useful for gargling. Mouthwash gargling can be done. Severe cases can be given with severe corticosteroids. Other than that, drug eruptions, due to the drugs we have known that plasma cell gingivitis or atypical gingivitis can be, but this is drug eruptions can be there. It could be drugs taken mouth or parenterally, it is called as medicamentosa, whereas if it is used as a local application, it can cause as stomatitis venetrata. So in the exam they might ask you stomatitis medicamentosa, what is that? So it is the drug allergy caused by the oral intake of the drug. So all these manifestations can be there, or it could be because of toothpaste, restorations, mouthwashes, all these can lead to drug eruptions or drug allergy. So the erosions, vesicular bullous lesions are there. So there are some diseases which mimic that of desquamative gingivitis, that is fastidious lesions, graft versus home. So in the exam they might ask you what is strawberry gums. Vaginous granulomatosis as a typical condition of strawberry gums, where it is erythema, enlarged, and it is in the color of the strawberry. So this could be a striking alternation. In case of patient with renal transplant patient, don't just look out for only the gingival enlargement. Look out for the lesion like this. There could be an erythematous lesion. It could involve it. Lichenoid lesions can be seen, which can be ulcerative also. Treatment, you can give corticosteroids and astromermin. Other than that, candidiasis and Kindler syndrome, this also have some manifestation in the oral cavity. So in the tongue, the finger, nails, it is due to the laminin 5 or collagen type affection. Psoriasis, normally the patient will have oral manifestation for psoriasis also. This is a very common skin lesions. ICAM1 is the responsible for it. You can have so many blisters like formation, patient complaining of itchy sensation. It has an oral manifestation also, especially in the gums. You can see the papilla, see the micro abscesses in the papilla here and migrating polymorphonuclear leukocytes. Here also there is micro abscesses seen in the condition. There is a pysostomatitis vigitans are there. This is very uncommon. So coming on to finally, what we as a periodontist always think about the flow chart. So if a patient comes to you with the complaint of whatever the clinical findings I told you so far, just first what you see is, without biopsy, first you have to take a proper history, diagnosis, then you can look out for any other systemic manifestation. If it is eye or other mucosal lesion, it could be BMP, that is cicatricial pemphiga. If it is skin and other lesions, it could be and erythematous erosive, it is erosive lichen planus. If it is due to the skin and other mucous, it could be pemphigus vulgaris. Like that, we have to divide the difference. If it is going to be acute, then it could be erythema multiforme. The better picture than this can help you. First, in the intraoral examination, morphology of the lesion, you have to know about it. What is the morphology? If you see erythematous lesion with epithelial desquamation and ulceration, it could be foreign body gingivitis, foreign body reactions. If it is erythematous lesion with epithelial desquamation without ulceration, it could be plasma cell gingivitis, atypical gingivitis. Plasma cell gingivitis, it affects the oral aspects of the attached gingiva, and it starts from the attached gingiva, proceed towards the marginal gingiva. Why it is called as atypical gingivitis? Because unlike the plaque-induced gingivitis, it is seen in the oral aspect of the attached gingiva, and it doesn't start from the marginal gingiva. It starts from the attached gingiva, proceed to the marginal gingiva. If you see a vesicular bullous lesion with ulcer, think about MMP. If you see the bulbous lesion that ruptured leave behind the erosions and irregular margins, think about pemphigus vulgaris. If you think keratotic papular or reticular plaque and atrophic ulcerative bulbous, you can think about oral lichen planus or chronic ulcerative stomatitis or graft versus host diseases. If you think about erythematous patches in the lip, crusting in the lip, erosions, ulceration, erythema multiforme. In case erosion, ulceration, linear erythema, which is not here. Linear IgA diseases are there, dermatosis, where vesicles and bulla rapidly disappear. I told you about dermatitis herpetiforms, where small vesicles are seen, which is herpes-like lesions can be there. Paraneoplastic pemphigus can be there, which is polymorphous. So psoriasis, you can see erythematous lesion with raised whitish borders or frank ulceration. This is the chart which has been given in the reference has been given down. I have not given the most of the references. I will be giving it at the end of my presentation. If given chance, go through this article. This will be very useful. They have done it for they have done a meta-analysis and find out this is how you can diagnose the disease based on the location, oral involvement, whether palate, buccal mucosa, gingiva, linear erythema, or it could be EB. If it is every site, it could be all this tumor. If it is only gingiva, think about ulcerative stomatitis, gingivitis, and in the case of gingiva. Sorry. So if it is involving the Nikolsky sign positive, then think about MMP and PB. If it is affecting the buccal mucosa, it is leukocyte adhesion deficiency disease. Coming on to the clinical history, ask the patient whether if it is acute or subacute. If it acute, it is erythema multiforme. If it is subacute, it can be oral lichen planus or mucous membrane pemphiga. General health, ask whether the patient had previous disease or therapeutic procedure. If it is due to the trauma, history of trauma, or after scaling, think about foreign body reaction. If it is due to transplantation or blood transfusion, it could be erythema multiforme. If it is associated with GIT disturbance and gluten sensitivity, it is dermatitis herpetiform. Malignancy, think about paraneoplastic pemphigus. In case of recent vaccination, think about pemphigus vulgaris. Many people, we are putting COVID vaccination, look out the finding like this. Inflammatory bowel disease, it could be Crohn's disease, keep in mind. If it is an infection, history of infection, it could be minor erythema multiforme. If the patient complains of frequent of symptoms, pemphigus vulgaris. Patient not aware of the symptoms. Here the patient is aware of the symptoms, it is pemphigus vulgaris. Patient not aware of the symptoms, it could be oral lichen planus. In case of topical substance, history of use of topical substance, plasma cell gingivitis or erythema multiforme. So, other than that, if you see the extraoral conditions, if you see in the conjunctiva, pharynx, multiple organ involvement, it could be mucous membrane pemphigoid. Skin, oral lichen planus. Conjunctiva, pemphigus vulgaris. Skin, GI, as I told you, DH. Other than that, skin, conjunctiva, all those things can be there. Internal organs, GVHD can be there. That is graft-versus-host diseases. Internal organs and other nose and this thing, you can have it for linear IgA diseases. So, all these findings, so whenever we see a case, first take a proper case history, do a intraoral examination, extraoral examination, histopathology, immunology, then go for the treatment. Don't immediately, as soon as you see, don't jump into the conclusion, okay, Dr. Selvakumar has told only steroid drugs. We'll start with steroid drugs. Nothing like that. So, you have to see the condition and monitor the patient regularly. We as a periodontist, we definitely call the patient for supportive periodontal therapy. So, whenever we call the patient, recall visit, you have to, these conditions have the ability to recur again. So, it is our duty to recall the patient. This is the way we can increase our practice also, and be in contact with the dermatologist and do it. So, onset, check chief complaint, these are the, you can have it as a checklist and you can do the treatment. Finally, the summary, pemphigus vulgaris, so it affects 4th decade, whereas remaining most of the things affect 6th decade. Erythema multiforme alone affects the younger people. Sex prediction, erythema multiforme male, most of them females. Clinical features, mostly vesicles, these two, pemphigus vulgaris, bullous pemphigoid, mucous membrane pemphigoid or mucocutaneous lesion, whereas lichen planus is oral and skin lesion. Histopathological, clefting is there, subepithelial and intraepithelial. I told you, epithelial cell, in between the epithelial cell, below the epithelial cells, that is what you call subepithelial and intraepithelial clefting most of the time, whereas lichen planus is T cell mediator, so it is hyperkeratosis. Direct immunofluorescence test, you can see all these are positive, okay, whereas it is not seen in lichen planus. Indirect immunofluorescence, if it is positive, then it is BP or it could be pemphigus vulgaris. Keep that in mind. So, finally, now the patient has come, you are given the tablets. Now, what are the instructions you are going to give the patient? Because we read about so much about Discomfort gingivitis, what instruction has to be given? Advise the patient not to use spicy, acidic or salty foods because that may be causing soreness to the mucosa. If patient presents with acute pain, recommend use of anesthetic mouthwash, as I told you, magic mouthwash. Advise the patient to keep their teeth clean by using soft brush, interdental brush, etc. because this can aggravate the Discomfort gingivitis condition. As I mentioned already, Discomfort gingivitis is not a disease by itself, it is a clinical manifestation. It is not caused by the plaque. This can aggravate the plaque accumulation. Perform basic non-surgical periodontal therapy if indicated. Perform regular anti-prophylactic periodontal maintenance therapy with proper plaque control regimens every once in 2 to 3 months. Advise the patient to use a toothpaste with a mild flavor and free from SLS. Sodium lauryl sulfate is one of the reasons for causing this contact dermatitis, or you can have plasma cell gingivitis or some of the condition for drug eruptions. So, avoid that. Advise the patient to discontinue using alcohol based mouthwash. Lot of studies have shown that alcohol based mouthwashes or mouthwashes containing SLS, you can use it. When a company pharma person comes to you and say that SLS containing toothpaste, you can use it for all the conditions. Don't get carried away. Keep in mind it is you who are going to read about it. So, SLS containing paste mouthwash should be avoided. Advise the patient to view of oral lichen planus to be checked on a regular basis. Otherwise, this can lead to squamous cell carcinoma. So, if smoking is a factor, ask them to do smoking cessation. Advise patient on use of alcohol consumption. So finally, coming to the conclusion, desquamatic gingivitis is not a disease by itself, number one. It is a clinical manifestation of various systemic disease. As a periodontist, I should be aware of, I should be able to diagnose the desquamatic gingivitis. Then it is going to be beneficial both for the patient as well as for your clinical practice. Desquamatic gingivitis, most of the time the treatment is steroids, local or systemic, and we have other options also. With the advent of photobiomodulation, photodynamic therapy, this has a very good scope. If many of the PG students here, they can do some studies on this using photobiomodulation and photodynamic therapy. Again, I am telling, keep it at the low level lasers. I am mentioning about low level lasers. Just because you don't have the low level laser, don't start using 980 nanometer wavelength or I am telling low level laser therapy has to be advocated. Proper tip, proper wavelength, proper watts is very important. It is less than 1 minute or 60 seconds, 45 to 60 seconds, you can use 550 nanometer wavelength without non-contact mode, you can use it. It has a very good results for that, but it requires multiple sitting. Patient will be, we will become a savior for the patient if you are going to do the treatment for with the low level laser therapy. If you elevate the pain of the patient, that is the main thing they have come for. They are not bothered whether it's a herpetiform, you have to elevate the pain. As a periodontist, we have a very important role to play in this. So proper diagnosis, proper treatment is very essential for a desquamative gingivitis. These are my references. These are the books. In Perio 2000, I referred all these books. These articles are quite interesting. If you find time, you can go through this. And these journals, whatever I referred, there are some of them are open access journals given by Dr. Rohit and Rohit Shah from Tarna Dental College, and Dr. Ravi Kiran and other people in Perio WhatsApp group whom they have provided me with these articles. It was very useful, interesting. This article is quite interesting, same way with this, and these articles were quite interesting. If you find time, and this is the one where I taken that the flow chart of it, and this desquamative gingivitis, a review article, it is very good for treatment. So you as a PG student, you want to mention what are the references. So these are the authors, various studies have been given by at various years. Still the cause is not clear cut for the cause, so we have to see for more. My acknowledgements to my principal, Dr. Kartika Kannan sir, who taught me during my PG days. This is how the vesiculobullous lesion appears. So always read, whenever read this chapter, always read with the clinical feature with that of histological feature. It will be very useful. There is a clefting taking place either at the epithelial level or at the subepithelial level or extending to the basement membrane layer and subepithelial layer. This can lead to the desquamative gingivitis. So always read that clinical features with that of histopathological features, and I thank the management of APDCH for giving me the opportunity, and Dr. Vivek sir and team from Saraswati Dental College, and Karpavalli madam, HOD of Seema Dental College, Oral Medicine, Dr. Uma, Oral Pathologist, Dr. Devanagi from APDCH Oral Medicine Department, who helped me with this topic, and my staffs in my Perio department, and especially my senior lecturer, Dr. Ramnath, and Balagopal PG student, who have helped me with this presentation. I'd be happy to answer your questions. If I know the answer, I'll answer you. If I don't know, I'll just find out the answer and tell you. Hope you would have understood at least little bit about this desquamative gingivitis. So the clinical feature, histopathological feature, and treatment, but you always have to keep in mind all those three diseases which are very common. Thank you. I'm extremely sorry for what happened initially with this network issues. I'm sorry. I'm unable to see you in direct, so I can see your appearance, but anyway, if you have any questions, I would If I know, I can answer it. Thank you so much again for giving me this opportunity.
Thank you, sir. So your lecture was an eye-opener. And believe me, sir, in spite of so much technical issues, I could see people joining from all over India, sir. So many people
you.
from North, so many students and staff
you,
from
sir.
South. And believe me, we were tired just to admit so many people. There's so many, every second people were coming in your lecture. And that's a compliment. So anyways, we have a few questions.
Thank you. I'm
sir.
honored, sir.
So there are a few questions. Kindly tell us your take on herbal products in the use and also hormonal therapy conditions.
Okay.
Like how does it, what do you think about hormonal therapy and herbal products?
Regarding herbal, I'm telling you, sir. Herbal,
Yes, sir.
they say we treat it for herbal, but lot of studies I've shown in that last slide. If somebody has taken the screenshot of it, I'll send it also. Herbal products itself causes sometimes the local stomatitis veneta. That has been studied. It has a multi-organ affecting it. They have been trying to use herbal products even for this Discomfort gingivitis conditions also. But sometimes the herbal products itself can cause stomatitis veneta also. That is the local application of Discomfort gingivitis. Drug eruptions, it can take place. As such, we have to know the composition of the herbal product, whatever they are using. And when I spoke to some of the dermatologists, they say even for this COVID also, they were using lot of herbal products. Now the people are landing with lot of kidney disorders and with liver problems, liver bleeding, like all these problems they develop for that. So my take on this is, herbal product studies have shown that it is beneficial to certain extent, but we have to be very careful when you are using the herbal products. We have to be very careful what is the consequence of it. As researchers or academicians in the college, if we try out with proper studies, we can tell about it. If it has been prescribed by proper people and if you are taking the drugs, then I don't think any mistake in that. I'm not against any herbal products. Herbal products are good, but herbal products itself can cause some amount of drug eruptions, number one. Number two, it can affect your kidney and liver functions. So that we have to be very careful. If it is a standard, if it is a Siddha or Ayurvedic, some standard drugs, then it is not a problem. Second question, one is herbal. Am I answered your question, sir?
Yes,
Sorry.
sir. Yes, sir.
Second,
yes, sir. And the role of hormonal therapy.
Hormonal therapy. Sir, previously when they thought it is due to the endocrinal problem, they started with the hormonal therapy. It has proved to be effective in some cases, and but still no conclusive evidence are there for the hormonal therapy. But along with that steroids, they have tried out various treatment plans. They have tried out cyclosporine, they have tried out with hormonal therapy. Not very conclusive, but they have tried out, they have shown some effectiveness with that of hormonal therapy. But in case of steroid sparing drugs, anything steroid along with any immunomodulatory reagents or dapsons have shown to be some effective in this case. So this is my take on it. Hormonal therapy, definitely if it is because of hormonal problem, we go in for hormonal therapy. But in case of Discomfort gingivitis, it is not a proven one. According to the journals, whatever I prescribe, if somebody sends me any article, so that I can update myself.
Sir, you mentioned about magic mouthwash.
Yeah.
So, like, can you tell us more about it?
Sir, actually for this stomatitis cases, and for it is actually indicated for stomatitis cases, what we do is, you have this mucin gel, that is antacid gel. Mucin GS contains antacid as well as lignocaine. Along with that, Benadryl cough syrup. These three mixed together, 2 parts of mucin gel, mucin GS gel, that contains ranitidine and this thing lignocaine, or you can have just a mucine gel. Along with that, you can add some lignocaine gel. Along with that, you can 2 parts of it to 1 part of Benadryl cough syrup. 2 part of it to 1 part of this, and you can use it for mouthwash. The patient will be relieved of burning sensation. I think it is available commercially also about Magic mouthwash, so it can be used. Magic, it is name is Magic mouthwash and it is available commercially. Sometimes I ask the patient to get this and it can be mixed and be used. One of my friend is a oral medicine. He has done a study on this. It has shown some interesting results with that.
Yeah. So what?
This is a palliative therapy. I don't know about the histochemical or other part of it. This is for the palliative therapy for patient complaining of burning sensation. This has shown to be effective. Burning sensation.
Sir, can you mention the brand name? Like, I know it's not a good idea, but requesting other people to please mute their mics, please. Thank you so much. Can you mention the brand name or anything which is?
I can't understand. Yeah.
So mute.
Yeah.
Okay. Sir, do you have a checklist? Do you have an approach paper that this is how we approach cases? Like, to be very true, you explained everything very good. But to be at the end of it, we need to understand that what are the most common problems, the percentage wise, and what are the most common treatment plans which our students should think about. And I would like to inform our students that this fabulous lecture is also available on YouTube. So anytime, at whatever time they want to go back, they can check the website of Saraswati Dental College and listen to this lecture which you said. So that's a very important thing which everybody needs to know. Sir.
Yeah. First, regarding the commonest condition which you see in our gingival condition, I am confining myself to a periophil. So mucous membrane pemphigoid, oral lichen planus, pemphigoid vulgaris. Epidemiologically, they have shown that these three commonly they show a manifestation of desquamative gingivitis, oral manifestation of desquamative gingivitis. Number 1. Number 2 is what is your second question, sir? Sorry.
So the most
standard treatment plan,
which our students,
standard treatment plan. First, eliminate the cause. What is the cause for it? Eliminate the cause. If it is drug eruptions due to drugs, stop the drugs. If it is some other reason, what is the cause? Stress and other factors, eliminate the cause. Number 1. Second, do a proper oral hygiene. Improve the oral hygiene because this can aggravate the desquamative gingivitis. Identify the underlying pathology. What is the cause for this pathogenesis? So then identify it and remove it. Then based upon that, give a local or systemic corticosteroids or immunosuppressant drugs. Coming on to this, as I told you, first you can start with, if it is local, you can start with spray. This fluconazole spray, up-control propionate sprays are available which can be used, or any corticosteroid sprays are available, or you can have an ointment, you can use it. Mouthwash can use it. But the problem with the ointment is, if they apply the ointment, due to the tongue movement and due to the easy removal from the saliva vanishes it away. So it doesn't have a long action. So ask the patient to instruct not to drink or eat for another half an hour. Then you can use the mouthwashes. After giving the mouthwashes, you can, different types of mouthwashes I told you, anti-allergic mouthwashes and other mouthwashes, combination. Tetracycline mouthwashes also have been prescribed. Cyclosporin mouthwashes also have been prescribed. If it doesn't respond with that, then you go for, you can give tacrolimus ointments are available. So you do this, so local or systemic ointments. Then in case if the patient is having, is not responding to that, then you can go for a blood, as I told you, plasmapheresis. That is, take out the blood from the patient, remove the autoantibodies, again transfuse the blood for the patient. So this brings out in case of severe conditions. It's not so easy, but I'm just telling you. Second, you can go for a labial veneers. patient will be complaining of recession after this ulcer. You should have seen in most of the pictures there are lot of recession were there. You can give veneers or you can do a mucogingival graft. Graft surgeries can be advised, or you can do, as I told you, laser photobiomodulation can be done, or you can do a surgical therapy of these things. So this is my treatment plan of it. Coming on to the diagnosis, as I mentioned many a times before my conclusion, first the proper case history is very important. Then diagnosis, clinical, intraoral as well as extraoral diagnosis is very important. Then if you are still you are not confined, I given you that all the differential diagnosis. Still if you are not sure, then go for the histopathological examination or immunofluorescence study. So this will give you an idea what type of a lesion is there. But as I told you, for improve your practice, these cases most of the time they report asymptomatic. Most of the time it reports first to the it is an accidental finding. Some of these clinical manifestations are seen accidentally, or these cases are seen in the by the general physician or dermatologist. So tell them if you see this condition and report to them, it can improve your clinical practice. I would even advise putting a poster. These are the oral manifestations of systemic disease. Make a poster of it, put it in your to your dermatology clinic, or for them to remember, okay, these cases has to be referred for periodontist or dentist opinion, like that. So you can just put those things with the posters. These are the some of the manifestation which we are treating, like that you can tell. So it improves your perio practice. Most of the time we say perio, oh no, we don't get a lot of cases. We are missing the cases. That is my ultimate thing. So these are the little things, and we are mostly bothered about only pocket, furcation involvement, bone graft, flap surgery. It is not. We have to treat the patient as a whole, not only for the disease what they have. You have to treat the patient as a whole, and it can be so it will improve your perio practice. Sorry if I gone too much overboard also.
No, sir. No, sir. It has been perfect.
Am I answered all your questions, sir?
Yes, sir. Though there are many questions, but time, what do I say? There's limited time. There is one of the questions that any alternative to steroid therapy for treating the diseases?
As far as, no, whatever I've read, whatever I've gone through it, steroids is the treatment. But I'm telling you, there is lot of scope for the periodontist to do this photobiomodulation, photodynamic therapy, along with maybe steroids are, and quick repair healing will be there. That is the important thing here. And as I told you, cicatricial and all, it forms with scarring. Since it goes into the connective tissue, scarring will be there. Most of the time the healing will be there. So the other than steroid means only these things are available.
One of the questions were, can you differentiate between linear gingival erythema and erosive lichen planus clinically?
Erosive lichen planus, it forms a erosive lesion confined to a particular linear gingival erythema. Now the terminology has come. Linear gingival erythema, it affects only the marginal gingiva. It affects only the marginal gingiva. This erosive lichen planus, it affects the wider area compared to linear gingival erythema. Linear gingival erythema affects only the marginal gingiva portion where you can see the erythematous lesion, but now in the latest classification they have removed it. They claim that it has not been there. Erosive lichen planus, it affects wider area. Linear gingival erythema affects only the marginal gingiva. This can be erosive lichen planus, can be seen in the buccal mucosa, palate, marginal gingiva, and it affects the wider area. This is my answer for it. I don't know, I'm sure about it. Yeah. Yes, sir?
So I think, though there are many questions, but since we are running short of time, sir.
Yeah.
So we will always seek your blessings. No problem. In case the time is limited, we can always be in contact with you. Our students, our postgraduates can contact you anytime, and probably you can help them out.
So this is my email address. or the other
Yes, sir.
one is silvaperio@gmail.com. Thank you for this humble opportunity. I shared whatever I know about it. So if anything, you can send it to my email address. Sorry, this email address all in small, or it can be silvaperio@gmail.com. You can send your query to that. And I would love to share my references, whatever I have taken, and whatever PDF, whatever is possible, I can share it with you. If any students is interested, I want everybody to, the knowledge has to be spread. That is my ultimate aim of the presentation. Thank
So
you.
nice of you, sir. So nice of you. So now I would request Dr. Vivek Benz to take over the presentation. Dr. Benz,
Thank you, Dr. Chetan.
can you?
Thank you,
Yes.
Dr. Silva, for the wonderful
you, sir.
presentation.
Thank you. I think I was
during
fast
the-
because due to the lack of time, I was rushing fast. I'm sorry if I've been
Sir,
very
it
fast
was,
in my presentation.
it was really wonderful. It was really wonderful. And you summarize in 1 hour. It is such a big topic. That's a really, thank you very much for you. Sir, during the presentation, we had some technical problem and our system goes down. Right now, you are host. So we cannot share certificate unless until you make me co-host for the presentation. Can you make me
Okay,
co-host?
no problem.
Can you make me co-host, sir?
Okay, sir. I'll just. Post எதுல பண்ணோம்?
It's okay, sir.
Yes.
We will thank you very much for your presentation and carve out time from your busy schedule. We will send you the certificate of appreciation.
Okay, sir. Thank you so much.
Later on. And thanks a lot to all the faculty members who have joined for this session. And thanks to all the postgraduate students who actually make this program a success. Thank you very much. Thanks all.
Thank you, sir.
Thank you.
Thank you, Dr. Manish, for attending. I think Dr. Manish was there. President
Manish
of
was there, Dr.
Vice
Sanjay
President
was there,
of
Dr. Kav was there.
ISP. Yeah, thank you, sir.
Yeah,
Thank you,
many.
sir.
I guess.
Sorry,
Dr.
I was unable to see many of them, so I'm extremely sorry for that. If I missed any names, sorry. Thank you, sir. Sir, I have shared your screen. I shared you as the host.
Oh, just a minute, sir. No, sir, I can't.
I don't know, sir. Okay, sir, no issues. You can send it.
We will send you certificate by email, sir.
Okay. No problem, sir.
Thank
you, sir.
Thank you
Thank
very
you, sir.
much. Thanks, sir.
Thank you for giving me the opportunity. Thank you, sir.
Thank you, Chief.